alterations in the renal and urological system. I'm going to look at congenital abnormalities or developmental abnormalities. So this would be seen in your pediatric population. And congenital abnormalities of the kidney and urinary tract occur in about 1% of newborns. And the structural abnormalities can range from minor to severe. Some of them are actually incompatible with life. First up is the horseshoe kidney, and this is the fact that the kidneys may fuse in the midline as they ascend, causing a single U-shaped kidney. Horseshoe kidney is the other way that we refer to it. So this is present in about 1 to 400, 1 to 600 births. Approximately 1/3 of patients are asymptomatic, and the most common associated problem is hydronephrosis, infection, stone formation, and tumors. Collectively, the structural anomalies of the renal system account for renal failure in children. It is more common in males, and you would also see this some genetic issues such as your PATHO syndrome or Edwards syndrome, trisomy 13 or 18. On physical exam, you may see abdominal fullness upon palpitation, and then most likely patients would be presenting with increased rates of urinary tract infections, hydronephrosis, renal stones. Renal agenesis, so this is the absence of kidney formation. It can be unilateral or bilateral, and that is failure of the uteric buds to form. And this can occur randomly or be hereditarily linked, and it may be isolated or also associated with some other abnormalities in other organ systems. Unilateral is about 1 per 1,000, and males are more affected, and it usually affects the left kidney as being absent. A single kidney is often normal, but it may also have compensatory hypertrophy before and after birth, and by the time the child is several years old, the volume of the kidney may approach twice the normal size, and then that puts them at risk for this hyperfiltration, and that increases the chance of developing proteinuria, hypertension, and chronic kidney disease. The extrarenal manifestations would be urogenital, skeletal, cardiac, to name a few. So then we talk about bilateral renal agenesis. This is called Potter's syndrome, and this is incompatible with life. So it affects male population, and that is related to either an abnormal development or normal progression or an isolated bilateral failure of the uteral bud. Potter syndrome is associated with a group of facial anomalies, wide set eyes and a parrot nose and low set ears and a receding chin, called Potter facies. There is also going to be oligohydramnios, which is low amniotic fluid, and then that is going to lead to reduced and underdeveloped lungs. And then the affected infants rarely live more than 24 hours because of pulmonary insufficiency. Approximately 40% of these affected infants are stillborn. And then we can detect this prenatally by ultrasound. Dysplastic kidneys. So this is during embryologic development, the ureteral duct grows into the metanephric tissue, and that is what triggers the formation of the kidneys, a condition called renal aplasia. If there is a smaller or a decreased number of nephrons, we would term that a hypoplastic. These conditions can be unilateral or bilateral. Renal dysplasia is resultant from abnormal differentiation of the kidney tissue, and it basically will give you a primitive glomeruli, tubules, cysts, and non-renal tissue such as cartilage. Dysplasia may be secondary to antenatal obstruction of the urinary tract from such things as uterocoeles, posterior urethral valves, prune belly syndrome. Unilateral is most common. If it's bilateral, we do have to take a look at it and make sure that it is not inherited polycystic disease. Polycystic kidney disease, and this is inherited about 1 in 1,000 for the autosomal dominant, and this is related to mutations of 2 genes, which would be PKD1 and PKD2. These account for presenting in late childhood or adulthood, and the gene products regulate growth and differentiation of the tubular epithelium, and we get defects in that, and then the formation of the epithelial cells in their cilium result in cyst formation, interstitial fibrosis, obstruction, and then loss of functional nephrons. We also have an autosomal recessive form. So this is on a PKHD1 gene mutation, and then this results in the absence of fibrocystin, which is required for tubular genesis. And there is what the polycystic kidney would look like, and you can see for adult, abdominal flank pain, low back pain, hematuria, urinary tract infections, juvenile hypertension, hepatomegaly, bilateral abdominal mass. Medullary cystic kidney disease, this is an inherited autosomal dominant defect leading to cysts in the medullary collecting duct. You will have parenchymal fibrosis, and that's going to result in a shrunken kidney and then worsening renal function. It is progressive and slow impairment, ultimately ending in end-stage renal disease. You will have no or minimal proteinuria with this. So a good way to remember this one is SpongeBob, because we actually refer to this as medullary sponge kidney. And a lot of patients will be asymptomatic on presentation, and it would be an incidental finding. They could present with stones as well as maybe urinary tract infections. Most of the time, this is a pretty benign condition, and you would just treat symptomatically if they had stones, urinary tract. Renal obstruction. So we classify them into upper or lower tract. If we're talking about the upper urinary tract, we're really looking at above the bladder. And then is there issues with stricture, congenital compression? Is there calculi or malignancy? When we're talking about lower urinary tract, then bladder, kind of below. So what happens with upper is that we will get a hydroureter because we have blockage. Urine accumulates, and that's what this is here. And then we also have dilation of the renal pelvis and calyces, and this is what we term hydronephrosis because it's actually in the kidney. So one of the biggest causes of an upper urinary tract infection is nephrolithiasis or renal calculi, and that is the presence of crystalline stones, which we call calculi, within the urinary system, kidneys, and ureter. And they are related to elevated levels such as calcium, uric acid, oxalate, and sodium. The risk for developing the urinary calculus or the renal calculi is influenced by a couple factors such as age, fluid intake, dietary consumption, geographic location, seasonal factors, genetic predisposition, and then other conditions that may affect the urinary tract such as hypertension, atherosclerosis, metabolic syndrome, obesity, and diabetes. So all of those increase the risk. Most people will develop their first stone before age 50 years. Most kidney stones are unilateral. So the most common types are calcium oxalate, struvite, 1 to 5%. And we have uric acid accounts for 5 to 10. So the patho is that the renal calculus formation is complex and related to supersaturation of one or more salts in the urine, precipitation of the salts from a liquid to a solid state. So that's that crystalline formation. pH also influences the risk of precipitation and calculus formation. The stone or inhibiting substances include potassium citrate, magnesium, and they are capable of growth inhibition. The size of the stone is going to determine whether it passes through the system and excreted through micturition. Smaller stones, less than 5 millimeters, usually pass through, whereas stones greater than 1 centimeter have no ability to pass through. So when the patients present with renal colic, and that is that colically, it can radiate into the groin because it's going to follow that pathway, and then you have referring pain off of it. That radiates to the lateral flank or lower abdomen, typically indicates the obstruction is mid-ureter, and bothersome lower tract symptoms indicate the obstruction is in the lower tract. So you can really follow where the pain is and kind of say where that stone is going to be. A lot of times it will be accompanied by nausea and vomiting, and then we will have hematuria. So when we look at a lower urinary tract obstruction, it's related to usually issues with the bladder, emptying the urine through the urinary outlet. We're looking at maybe a neurogenic or an anatomical issue. This would include neurogenic bladder, overactive bladder, prostate enlargement, urethral stricture, pelvic organ prolapse, cancer. Again, we pretty much say below the bladder for our lower urinary tract obstruction. When we're talking about these types of issues, we understand that it is a very complex process for micturition. Nervous system highly involved to control sensory and motor bladder functioning, and the neurologic disorders are usually pontine micturition center, and that will result in detrusor hyperreflexia. So incontinence is the involuntary spontaneous urine loss that occurs either with strenuous activity, such as in stress incontinence, or is associated with uncontrollable sense of urgency, cause urged incontinence, or both, which we get mixed incontinence. So these may be caused by alterations in anatomic support. Is there a neuromuscular issue of the pelvic floor? Or it may just happen in idiopathic Risk factors are multifactorial, such as increasing parity, vaginal delivery, episiotomy. These are all more with stress incontinence, and that is due to a weakening of the wall and muscles, connective tissue. There may also be damage to the duodenal and pelvic nerves. So all of that happens with delivery can lead you to the stress incontinence later in life. Obesity, so excessive weight, can increase the pressure on the pelvic tissues, and that will lead to strain, stretching, and weakening of the muscles, nerves, and other pelvic structures. Older, so dementia, this creates a situation where there's an increased incidence of incontinence because they are missing their toileting cues. When we talk about incontinence, we do need to rule out other complex, potentially life-threatening underlying conditions such as spinal cord compression, MS. Pelvic organ prolapse. So this would be for your females. So we could have a cysticelli, which is bladder prolapse, recticelli, which is prolapse of the rectum or large bowel, enterocelli, prolapse of the small bowel, and then all of these are often associated with a prolapse uterus. Okay, let's get into renal failure. So we have three types of mechanisms behind renal failure. We have pre-renal, intrarenal, and post-renal. And we're going to go into each one of these. Just a couple classifications so you're aware. So we have acute kidney injury, which is evidenced by a rise in serum creatinine and abnormal urinalysis that has developed within a few hours to days. Here is your serum rise of greater than or equal to 0.3 milligrams per deciliter relative to known baseline within 48 hours, or an increase of greater than 1.5 times baseline value within 7 days. Decrease in urine volume, those would all be your evidence of acute renal failure. Chronic is evidenced by a persistent GFR less than 60, or evidence of kidney damage such as albuminuria, or abnormal findings on an ultrasound. So you have some type of evidence that is persistent. We do have a subacute, and that encompasses the kind of the time frame between acute and chronic. And it is any decrement of renal function in less than 3 months. So between the 48 hours and the 3 months, we call that subacute. And then our progression to end-stage renal disease, and that is when less than 10% of the kidney function is resulted. Acute kidney injury, hallmark is azotemia, and azotemia is increased serum urea levels and frequently increased creatinine levels. So your normal creatinine is 0.7 to 1.2, 1.4, all depends on your labs, but basically within that range. And then what will happen is you have increased serum urea levels, increased creatinine, and then we have renal insufficiency causes azotemia. Both azotemia and uremia indicate an accumulation of nitrogenous waste products in the blood, and the uremia or uremic syndrome, so that is going to be evidenced by blood urea and creatinine levels. And then we will also have fatigue, anorexia, nausea, vomiting, pruritus. Uremia is basically evidence of a buildup of toxic substances. So we have pre-renal, and that is a failure due to impaired renal perfusion. So think hypovolemia, heart failure. Somehow, when we get into the kidney, we have decreased perfusion. So it's going to be before it actually gets into the kidney. Something is happening systemically that is going to impair that renal perfusion. Intrarenal means that there is direct injury to the parenchyma, such as acute tubular necrosis or nephrotoxic ATN, and we're going to get into a couple examples of that. Post-renal is going to be outside the kidney and into the ureter, so something happens below the kidney, and that is usually related to an obstruction or maybe an enlarged prostate or tumor. So that is the best way to kind of look at it. And here on that schematic, so pre-renal, before we get in, intrarenal, in the obviously, and then after, we're thinking more obstruction. So the clinical symptoms, regardless if whatever type of renal failure is going on, may be asymptomatic depending on the severity of it. You would have a decrease or lack of urine. You may also have polyuria, confusion, flank pain, paroxysmal nocturnia, dyspnea, hematuria. We would have hypo or hypertension, edema, decreased urine output. Labs, we're going to be looking at all of those kidney function that we talked about in the A&P review. Also, phosphate's another one. And then is there a metabolic acidosis? Labs are important when we're trying to determine cause of the acute kidney injury. And there again is that increased serum creatinine. But then we have a blood urea nitrogen and creatinine ratio. So that is going to assist us with determining where the problem is. The other thing that we would look at is fractional excretion of sodium. If it's less than 1%, then we think pre-renal azotemia. Your urine osmol and sodium concentrations are also going to give you a lot of information. Here's a nice little schematic. So you can see here all the things that would cause your pre-renal AKI. Over here are your intrinsic renal diseases. So these would be all of your intrarenal, and then post-renal, not too many. You know, basically there's got to be some type of obstruction happening down here, whether it's related to the bladder, is there a tumor, is there a stone? You're looking at that. So this is a good slide here just to kind of put it all together. All right, pre-renal. So basically what will happen with the kidneys is there's going to be lower perfusion pressure, and that's going to enhance sodium and water reabsorption. Those baroreceptors in the carotid artery and aortic arch respond with sympathetic stimulation, and again, related to hypoperfusion, diuretic use, CHF. When we're talking intrarenal, so this would be an acute tubular necrosis, and that is injury and necrosis of those tubular epithelial cells. And what's going to happen is that there is some kind of ischemic or toxic insult, and then these cells are necrotic and they plug and create an obstruction, and that is going to result in decreased reabsorption of blood urea nitrogen, decreased reabsorption of sodium, and inability to concentrate urine. Tubular necrosis is the most common intrarenal AKI. Acute interstitial nephritis is another way that we could get an intrarenal, and this is due to a drug-induced hypersensitivity, type 4, and this is going to attack the interstitium and the tubules, and this is going to be a T-cell attack. Here you're going to see eosinophils in the urine. Your most common medications, there are more than 100 of them. Antibiotics would be the big ones here. Penicillins, your sulfonamides, cephalosporins, fluoroquinolones, diuretics, NSAIDs. So away, it would be typically developing between 1 to 9 weeks after exposure to the medication. Here are the 5 main ways that we remember those medications. So P, diuretics, sulfa agents, pain-free, your NSAIDs, penicillins, and cephalosporins, PPIs, and rifampin. Other things that may cause acute interstitial nephritis would be some autoimmune issues such as lupus or sarcoidosis. Here are your signs and symptoms. Post-renal azotemia, so this is due to the obstruction of the urinary tract, and we have decreased outflow, results in GFR, azotemia, and oliguria. During the early stages of the obstruction, increased tubular forces push BUN into the blood, so that is why you have a serum BUN creatinine ratio that's greater than 15. Chronic renal failure, so this is proteinuria or hematuria and a reduction in consistent GFR for greater than 3 months duration. Most common causes are diabetes and hypertension, and it is often unrecognized until we are in those more advanced stages. And 1 in 10 Americans has chronic kidney disease. It does affect certain ethnicities more than others, such as African American, Hispanic, and those with family members who have a history. The pathophysiology is complex. There is some method of renal injury, and then once that has occurred, there's a cascade of events. In response to that renal injury, result in interglomerular pressure. The kidney attempts to adapt to nephron loss, but there is an increase in the permeability to the macromolecules, and we start getting evidence of things spilling out that are not supposed to be spilling out. The 2 most common syndromes associated with glomerular disease are nephrotic and nephritic syndromes. Nephrotic syndrome is characterized by proteinuria, hypoalbuminemia, generalized edema, and hyperlipidemia, and we're going to go into that. And nephritic syndromes are characterized by hematuria, proteinuria, azotemia, and hypertension. So we're going to go into both of these. You can see the difference with the etiologies here. from nephritic versus nephrotic, and then we do have some that overlap. So nephrotic starting points. So these are glomerular disorders that are characterized by extensive proteinuria, and that's a daily protein loss in the urine of 3.5 grams or more, and we call that nephrotic range proteinuria. That will then result in hypoalbuminemia, which the plasma albumin levels will be less than 3 grams, and that is going to result in those shifts. We will have edema, and this is the most common presentation. We will have evidence of hypogammaglobulinemia, which will put the patients at risk for infection. There may be a loss of antithrombin 3, which would lead to a hypercoagulable state, and hyperlipidemia and hypercholesterolemia, which is going to result in fatty casts in the urine. The genesis of the hyperlipidemia is obscure, but they believe the hypoalbuminemia triggers increased synthesis of lipoproteins. So this kind of impacts that. So regardless of the cause of the nephrotic syndrome, there is a common pathway, and that's the derangement of the capillary walls of the glomeruli that results in increased permeability to those plasma proteins. So that glomerular basement membrane is altered and increased permeability. So with that long-standing heavy proteinuria, serum albumin is decreased, giving rise to hypoalbuminemia and a drop in plasma colloid osmotic pressure, which allows for the leakage of the fluid from the blood into the extravascular spaces. That results in a decrease of intravascular volume, and renal blood flow triggers the RAS system, which promotes retention of salt and water by the kidney. And then this is exacerbated by reductions in cardiac secretion of those natriuretic factors. And that continues with that proteinuria, salt and water retention, then further aggravates the edema. And that's what's going to go into anasarca, which is that generalized edema. So the two most common, so we do have primary and secondary. So primary is going to be primary glomerular lesion, and that is focal segmental glomerular sclerosis or minimal change disease. So those are the two most common. Minimal change disease is seen in children, and focal segmental glomerular sclerosis in adults. Secondary causes would be related to autoimmune, such as lupus or an amyloidosis, and then here is a diabetic nephropathy. Here is a nice schematic too to look at your etiologies. So let's take a look at proteinuria. So glomerular proteinuria develops when the components of the filtration barrier are disrupted by disease. And that is going back to those podocytes and the filtration barrier. So when we're taking a look at the podocytes for proteinuria, so there's 3 categories of proteinuria: glomerular, tubular, and overflow. When we're talking about glomerular proteinuria, it develops when the components of the filtration barrier are disrupted by disease. So we have a primary insult, and then we're hypoalbuminemic due to a urinary loss of albumin. So let's take a look back at that podocyte. So here we have the glomerulus. So there are those mesangial cells, and that's kind of in that more internal environment. And there we have the podocytes. So remember, they have those foot-like processes, and that's right up against the basement membrane. Here is the urinary space. We have the parietal epithelium, and then we have the visceral epithelium, which is consistent with the podocytes. All right, that's all continuous with the visceral epithelium. So what happens we have the fenestration. You can see here evidence of that fenestration. And those fenestrated endothelios, they are responsible for the glomerular filtration. So normally the glomerular filtration system is highly permeable to water and small solutes, and are impermeable to most molecules that are large and definitely albumin. And then that selective permeability gives that discrimination among the protein molecules according to size. Podocytes are important diffusion barriers for plasma proteins, and they are largely responsible for the synthesis of the glomerular basement membrane component. When we have a mechanism of injury, we get damage to those podocytes, and then that allows for proteins to spill across, and then that's how we get protein in the urine. So the clinical presentation would be edema, and we're going to have periorbital, especially in child nephrotic syndrome, lower extremity, and genital. There is that frothy urine, which is evidence of proteinuria. Ascites, weight gain, fatigue, shortness of breath, all related to those fluid volume shifts. And then on physical exam, you would see hypertension, edema, and this is leukonkaya. So these are called Merkel lines, and this is a sign of hypoalbuminemia. So minimal change disease, questionable immune-mediated mechanism, and most common cause of nephrotic syndrome in children. Peripheral edema associated with heavy proteinuria, and hypoalbuminemia, hyperlipidemia, usually idiopathic, could be associated with some type of cancer. Focal segmental glomerular sclerosis, this is the most common cause in adults. And this is a chronic pathologic process. Again, injury to those podocytes. So once you know the A and P of it, it makes sense as to why you're seeing the filtration issues with the increased protein. Membranous nephropathy, this is the most common cause of nephrotic syndrome in Caucasian adults, usually idiopathic, related to autoantibodies to the phospholipase A2 receptor present on the podocytes. And this would be secondary to a hepatitis, an autoimmune disease, certain drugs, and then we would get some new membrane growth between the subepithelial immune deposits, which leads to a classic spike and dome appearance to the glomerular area. Diabetic glomerular nephropathy, so this would be the thing that you see with that chronic disease of diabetes. This is evidenced by microalbuminuria and then a progressive fall in GFR. The pathogenic process occurs related to glomerular hyperfiltration, which is the albumin leak, related to the podocyte. In this, we also have basement membrane thickening, hypertrophy, sclerosing, which lead to that. And this is a response to hyperglycemia and the glycation of the matrix protein. Another one that may cause kidney issues is systemic amyloidosis. And this is derived from an immunoglobulin light chains, which is primary systemic amyloidosis. And this is associated with a plasma cell dyscrasia. Kidney is the primary target organ in amyloidosis, and this would be evidenced by monoclonal light chains, and you would test for that. They deposit extracellularly, resulting in disruption of that glomerular basement membrane. The light chains interact with mesangial cells, which catabolize them into fragments and form amyloid fibrils. So when we talk about nephritic syndromes, nephritic disease, this is a renal disease characterized by glomerular inflammation and bleeding. We would have limited proteinuria, we would have oliguria and azotemia. There would be evidence of salt retention with periorbital edema and hypertension, but you're going to have evidence of that inflammation and bleeding, and that is going to be your casts and dysmorphic red blood cells in the urine. Causes of nephritic syndromes include IgA nephropathy, post-infectious glomerular nephritis, and rapidly progressing glomerular nephritis. So post-streptococcal glomerular nephritis, this is a pathologic glomerular injury related to exposure to group AB hemolytic strip infection of the skin or pharynx. So you have to be exposed. And then we would get extrinsic antigens that are trapped in that glomerulus. This is considered a type 3 hypersensitivity. We would have decreased complement 3 levels. It is usually self-resolving. This syndrome usually has an acute onset and caused by inflammatory lesions within the glomeruli. Rapidly progressing glomerular nephritis, this could be related to Goodpasture syndrome, which is a type 2 hypersensitivity. And we get antibodies to the alveolar basement membrane, resulting in hemoptysis and lung disease. And here we get an antigen, form antibodies, attacks the basement cell membrane, kidney, and lung, resulting in basement membrane leaking, causing oliguria, hematuria, some proteinuria, pulmonary hemorrhage, and then that will result in renal and respiratory failure. Alport syndrome, this is a collagen type 4 mutation that results in a normal basement membrane. This is X-linked dominant disorder. Key characteristics are that there is ocular involvement, renal involvement, and sensorineural hearing loss. So 85% are this X-linked, but there is autosomal recessive and dominant Alport syndrome as well. And then that mutation is for the genes encoding the type 4 collagen, and due to those mutations, which are a major component of glomerular basement membrane, that's going to result in issues with the podocytes, the endothelial cells of the normal basement membrane. IgA nephropathy, also known as Burke disease, is an IgA immune complex deposition in the glomerular mesangial cells, and this would be consistent with hematuria and upper respiratory tract infection and gastrointestinal affection at the same time. So presenting symptom is hematuria, some proteinuria, but we're nephritic range, not nephrotic range proteinuria, hypertension, and edema. Again, they all classically present with those common signs and symptoms. It is idiopathic, but it can occur secondary to some other diseases such as HIV, AIDS, maybe a small vessel systemic vasculitis, membranoproliferative glomerulonephritis. This is immune complex and or complement protein deposition in the mesangium and subendothelium of the capillaries. And this results in remodeling of the capillary wall, and it may be secondary to hepatitis B or C. And this would be related to those complement factors. Urinary tract infection, infection of the urethra, bladder, or kidney, uncomplicated, complicated, acute versus recurrent. And it is from the ascending infection, increased incident in females because we have a short urethra, elderly and infants, and risk factors are related to being female, and then sexual intercourse, urinary stasis, incontinence, diabetes, BPH, and catheters. The way that we classify complicated versus uncomplicated: uncomplicated is non-pregnant, no anatomical abnormalities. Pretty much anybody who's pregnant with anatomic abnormalities, pylo, and men we also consider complicated because men do not get urinary tract infections very easily. The presentation is via the ascending pathway. Colonization of the vagina occurs, and then it ascends into the urinary tract and follows it up. The urinary tract is highly receptive to E. coli as the #1 cause of our ascending pathogenesis. So the bacteria adhere very well to the erythromeatus, and then there's stasis of the bladder, impairs defense against infection provided by a bladder emptying. Type 1 pili help with bacterial adherence. Intercystitis is a chronic clinical syndrome of urinary frequency, urgency, and pelvic pain. And then symptoms will vary related to bladder filling, and it usually has a situation of exacerbations and remission. This is a diagnosis of exclusion after you rule out some other etiology. Common range is 20 to 60 years old, and it has a 2.6 per 100,000 incident rate. Various etiologies have been theorized, but none explain all of the signs and symptoms and presentations and clinical courses. So these would include things like an autoimmune disorder, hypersensitivity issues within the bladder, and then maybe some pain issues. With that, with having an etiology that's unknown, the patho is also poorly understood. And they theorize that there could be upregulation of nerve growth fibers, leading to chronic stimulation of that afferent pain pathway. And then that's going to lead to pelvic floor dysfunction and musophageal trigger points and pain. I'm going to switch over to the males. So prostatitis. So this is inflammation of the prostate. There's an age differential with presentation of prostatitis. As you can see, if we are in the younger category, less than 35 years, we are thinking STIs. If we are in the older category, we're thinking more of the enterotoxins, such as E. coli, P. aeruginosa, or K. pneumoniae. You can have some other non-infectious causes. Also, smoking and alcohol increase your risk of this. The patho is basically there is interprostatic reflux. So that's the urine into the prostatic duct. And then that takes the ascending path refluxes into the prostate, and then that contributes to the development of the infection. So that's the patho in about 5 to 10% of the cases. And then there are other things that they believe are related for IgA, suggesting that there is an immunologic response. Common presentation is dysuria, frequency, pain in that prostatic, pelvic, or perineal region. There may be a bladder outlet obstruction, fevers, and chills because it is, if it's related to an infectious process. And then on exam, you would have an enlarged prostate, tender with acute, less tender with chronic. Chronic prostatitis is characterized by persistent pain and recurrent UTIs. When we have persistent pain in the prostate, we call it prostodynia. Acute pylo, from the Greek pylo meaning pelvis, nephros kidney, and itis inflammation. So this is a severe infectious inflammatory disease of the renal parenchyma, calyces, and pelvis. So really attacking the entire kidney. Can be acute, recurrent, or chronic. and it is really related to enteric bacteria that ascend from the lower urinary tract or spread pathogenesis. It's from the blood. Fever is the main determinant between cystitis, urinary tract infections, as this is going to put you in that more severe presentation. Another high yield finding is that you're going to have that CVA tenderness. Nausea and vomiting may be present. We can have complicated and uncomplicated of this as well. When we get into the complicated status, you're looking at issues with immunosuppression, history of diabetes, instrumentation, so any cystoscopy, hemolytic uremic syndrome, characterized by microangiopathic hemolytic anemia, thrombocytopenia, and nephropathy. Just covering this again because we do have the neuropathy and it's an uremic syndrome. So this is common in children and are related to an epidemic gastroenteritis, varotoxin producing E. coli. Etiology includes infection, drugs, bone marrow transplant. Clinical presentation is a child less than 5 years old that presents with bloody diarrhea. Let's take a look at some of the cancers. So Wilms tumor, this is a genetic and it's got that 2-hit hypothesis with tumor suppressant genes and chromosomal inactivation. This is the most common renal malignancy in children. It will present with a unilateral, painless abdominal flank mass, rarely presents bilaterally. Here's a picture of it. And it will present within the first 2 to 5 years of life. And there is a risk of developing a Wilms tumor in certain congenital overgrowth syndromes. Your genital anomalies would be something like hypospadias, ambiguous genitalia, cryptocortism. Some other would be trisomy 18. So the patho is a multi-step process that they thought developed via a pre-malignant stage, and then there is that 2-hit hypothesis, which means there are 2 rate-limiting mutational events that occur sequentially. Renal cell carcinoma is a malignancy arising from the renal parenchyma or cortex and accounts for about 90% of all kidney cancers. So mean age is about 64 years old, and kidney cancer compromises approximately 4.2% of new cancers per year. Smoking is a well-established risk factor for renal carcinoma. Obesity and hypertension are also big risk factors associated with this. If there's elevated systolic and diastolic blood pressures, 2 to 3-fold increased risk of developing renal cell carcinoma. So surgery is curative for 90% of cases. If there's metastasis at diagnosis, it's poor survival, but we are improving our targeted therapies, and that's that personalized medicine. So these patients are going to present with hematuria. They are often asymptomatic. They may have flank pain or a palpable abdominal mass, but more than 50% are going to present with an asymptomatic presentation. So it was an incidental finding, but it still could be quite problematic, and we have to work it up. So these are the 2 main ways that you're going to have your clinical presentation. So then you're going to be looking for CBC, any evidence of paraneoplastic syndromes, which would be anemia, erythrocytosis. You would be looking at lactate dehydrogenase, and that, if it's elevated, is a poor prognostic indicator. You would be looking at corrected calcium, liver function tests, so you would be doing a complete workup here, and then you would ultimately get a CT abdomen and pelvis looking for a renal mass. Bladder cancer. So this is another one that is a very common cancer. And you can see here, 10th most common cancer, more than 90% of new cases occur in older patients. This will also present with gross or microscopic hematuria, and that's the primary symptom of bladder cancer. And then screening for hematuria appears markedly to improve the prognosis of bladder cancer. Smoking is one of the highest risk factors that is preventable. Carcinogen exposure, pelvic irradiation, systemic chemo, higher risk for male, and then chronic bladder infections. Other chemical carcinogens put at risk for this has to do with in the rubber and dye industries, also coal, oil, petroleum, roofing industries, painters, and hairdressers would be an occupational risk. Okay, epidemiology. So Egypt, Western Europe, North America have the highest incidence, and then we have lowest incidence in Asian countries. Have highest incident rates. However, African American have the lowest survival rate, and that goes back to health disparity. Okay, that is it for selected renal pathologies.